enhance immunotherapies, Neil?
So thank you for the invitation to talk here. So this is a discussion that is going to be ongoing. We right now at the beginning, and it's wonderful that we can have this kind of a discussion going forward. You have heard from Dr. Sursek the standard therapies. You've also heard about the immune therapies. At this point, I'm just going to give you my take on what this is. So enhanced immunotherapy can be considered in many ways. And in colorectal cancer, in microsatellite stable colon cancer, enhanced immunotherapy is getting it to work in the first place. We need to make these tumors inflamed and see efficacy, and then we can work on making it better. If we were talking about MSI-high tumors, which I'm not talking about, the discussion is going to be how can we improve on the successes we've already seen. So one of the strategies that is really coming down the pike that Andrea referred to was this whole idea of MEK inhibition. And we are really at the beginning of that, and we're going to learn how we can enhance that. So just as a reminder of what we're talking about, which might give us an idea of how we can take this forward. So this MAP kinase pathway is essential in cell survival in tumors, but it's also very important in T cells. And the current thinking is that naive T cells that are going to initially proliferate will use this pathway in order to initially expand. But once there's T cell expansion and there's continued antigen stimulation, that pathway will start to downregulate those activated T cells, cause suppression or T cell exhaustion. So if we can stop this overstimulation, those T cells will then become revived and able to kill their target. We're also learning that besides an effect on the T cells, there's an effect on the tumors because the tumors themselves become more immunogenic. They increase the expression of tumor antigens, which might be mutations or whatever the tumor antigen is in colon cancer. And ultimately, we don't know what that is yet. But if we say that these are mutations, there's presumably increased expression of those. And this is this has been observed before in melanoma with BRAF inhibition. Also, what we're seeing on these patients is that there's increased expression of MHC class 1, i.e. the tumors want to be seen by the immune system. They are making themselves more visible. The initial clinical trial that you heard about did show efficacy, but also showed this proof of principle. So this is not colon cancer. These were other patients on the same clinical trial. But you can see that after just suppressing this MEK inhibition, there was increased CD8 T cells in the tumor, also an increase in MHC class 1, which was even more enhanced in combination with anti-PD-L1 therapy with the atezolizumab. The initial responses are important. This is the proof of principle that this can work. But like other immune therapies and other types of tumors, what we really need to understand is whether the true benefit is from the responses or the duration of response in those subset of patients that do benefit, i.e. the importance of markers within immunotherapy, markers that we don't yet know in colon cancer or for many different types of tumors, but we're trying to figure that out. So what you see here are these ongoing responses. This is months, right? So 12 months in the initial phase 1 trial. So that's really what we're going to keep our eye on as these trials become more developed. And this is a slide that I showed at ASCO 2 years ago, just a comparison. Don't look too deeply into the slide. But initial impressions, the shapes of these curves do resemble each other. This was the initial nivolumab and MSI-high that Mike Overman presented back in 2016. That's the initial slide that Jana Bendel presented of Cobi-Atezo in microsatellite stable colon cancers. So we're hoping, again, for this tail on the curve for enhanced benefit in a subset of patients. In terms of the toxicities compared to the standard therapies, which is really the subject of this debate, the toxicities are very different. Immune therapies can't be directly compared to those of targeted drugs and drugs like regorafenib, but the overall grade of toxicities is somewhat comparable, but these are different types of side effects, right? So the point being here that although immunotherapy does have side effects, it's not inferior to regorafenib in that regard by this comparison. What we learned from the larger trial, so this is the same phase 1 trial that enrolled more patients, and now we're up to about 84 patients. Yep, 84 patients that have been treated, and we are seeing the subset of patients with benefit, albeit now an 8% response rate compared to 17%. So we're seeing less patients respond. Does that mean that we're less enthusiastic about the study? And I would argue, no, it doesn't. Because again, we are looking at this tail on the curve, and what the point another point that was made in the study is that it's independent of RAS status. So both wild type and mutant RAS can benefit. So this is not MEK inhibition downstream of a mutant RAS. And I think one of the key points that has been made previously in the study, and we need to focus on here, is that if you look at this PFS and overall survival curves, right? So the curves are important, but what was observed is 43% of patients are still alive at 12 months. This is not what we would expect to see from a patient population that enrolls into these late-phase clinical trials. So again, the focus here, not necessarily on the initial responses that we're seeing, but the duration of the responses and the duration of the clinical benefit. So this is very intriguing. And we are awaiting the data from the Emblaze 370 trial. We don't know yet when this data is going to come out, but this is going to tell us about Cobia-Atezo that we've observed versus the benefit from atezolizumab by itself. We don't think that PD-1 or PD-L1 by itself is effective in colon cancer. This is a larger trial. This will tell us about the durable benefit of a PD-1 or PD-L1 by itself compared to regorafenib. So what we are looking forward to in this trial, so this just as an overview of what's coming down the pike. So these are patients that have been previously treated with 2 regimens. 360 patients were enrolled. There are 90 sites around the world that are enrolling these patients, so a very vigorous enrollment. Primary endpoint is overall survival. There are multiple secondary endpoints, including response rate, PFS, duration of response, quality of life, safety, pharmacodynamics, and pharmacokinetics. And this is a 3-arm study. The one arm is atezolizumab every 3 weeks, a standard way that this is given in other types of tumors and other trials. Then the experimental arm of atezo now every 2 weeks. We don't think there's a difference between 2 weeks and 3 weeks. It's just really the companion regimen with Cobi given at 60 milligrams daily for 3 weeks, followed by a 1-week break. That's going to be compared to standard dosing for regorafenib. Patients are treated until progression or unacceptable toxicity. So we eagerly await these data. So I think the take-home points that I want to make is that enhanced immunotherapy, however you define it, here we're defining it as MEK inhibition, rescuing exhausted T cells, making the tumor more visible to the immune system, is compelling based on the early phase trials that we have seen, especially when we consider the efficacy that we see in later trial therapies that Dr. Sosek had described to you. The phase 3 data is pending for cobimetinib and atezolizumab, and it's really nice to be able to stand up here and say we are looking forward to phase 3 data of immunotherapy in microsatellite stable colon cancer. But for now, we can look back and we can see that this proof of principle has been achieved for immuno-oncology in colorectal cancer, and there certainly is more to follow. Thank you for your attention.